still gonna finish on time. Heart failure we've already talked about in PD1. Do you guys do heart failure at cardio?
No.
No.
This was so everything I did yesterday was like you guys had just done.
Yeah.
This stuff is new. Okay. So Lauren's pretty good at heart failure, so I'll try to live up to that. The heart has it's pump failure is really what heart failure is. It's inadequate perfusion that occurs because your heart cannot pump adequately, and the reason why your heart cannot pump adequately is either due to too much preload or not enough squeeze, and that again goes to the cardiac output formula. So too much preload and squeeze. A lot of this has to do with the stroke volume portion of the cardiac output formula. We all need this term EF. Oh, the EF is low, or what's normal EF? Well, normal EF is around 55. That stop. Is it too loud?
No, you're good.
You guys still hear me?
Yeah.
Normal EF is like 55 to 60%.
Yeah.
Yeah, it sounds like it's not working.
I'm sorry.
If your EF is like 75 or 80, is that like bonus points? Why? I thought higher the number is good.
Hypertension.
Not hypertension. Well, what is ejection fraction? That's the reason why. So it's stroke volume over your end diastolic volume. So because math, if your denominator is smaller, your equation will get bigger. But the problem is what the denominator actually is. It's end diastolic volume. So if your end diastolic volume is like reduced, let's say you have, this is an example, is 150, you make it like 15, it's going to be a much higher number. So what a higher EF tells you outside of that range is an unfilled heart or an inadequately filled heart. So an EF of like 70, 75, 80%, we call that hyperdynamic. They need more volume. They need more preload. It's not the optimal range. You need to be in the optimal range. Ideally, 50 to 60%, somewhere in there. Now, conversely, if your denominator is very large, your EF will go down. So if your filling volume is like 200, 300 ml, well, that's going to make your ejection fraction go down, and that's going to be too much for the heart to work. So that's overload. So just like you guys did lab medicine, like electrolytes and stuff, what's normal potassium?
3.5.
All right, what if your potassium's 7?
Too high.
It's good, right?
No.
What if your potassium's 1?
Very
Okay, so it's the same thing. You have to be in the optimal area. You cannot just say, oh, this number is good. And people don't really get that. They say, oh, the EF 70, great. It's like, no, like that's not good. That means that just tells me they're dry. I hear EF of 70, I'm like, give them a liter of fluids because if you understand the formula, that's kind of what that means. Another way of understanding that is they call it like if you do an echo when you have someone with a hyperdynamic EF, their ventricles are going to be hitting the septum, so you don't normally want that. Okay, so now you have your heart. So this is RV, LV, right? And then when there's like a squeezing, right? It's increasing pressure. It's increasing. This has squeezed. Then it goes through here. It's able to accomplish that with pressure, with volume, right? Which is preload, and the pressures which have to overcome with afterload, and contractility. So to do that, this has to flex, right? Now, it should flex, but to a certain degree. What if in the flexed phase of that heart, it looked like that? It's like no volume. It's like slap. They call it slapping against the septum. This A is like slapping against B. That's too much, right? So that it shouldn't be like what's a good example? Like I guess if you're doing like bicep curls, you want to do like short curls to get like a more cut. Like it shouldn't be like you're going all the way in like that. Like, that's wrong. So you have to actually be like right in the middle of what you want to do. And also like if you're too weak and the weight's too heavy for it, you're not gonna get anywhere. That's the same thing. So if your EF is low, you can't even get the weight up. If your EF is high, it's way too low for you, and you're doing like 5-pound dumbbells. You have to be right in the middle of what you want to be. That's what EF is. So if you that makes sense.
Yeah.
Has that been explained to you before?
No.
What is the actual optimal range? Just 65?
Yeah, it's a percentage based on body surface area and everything else. So like there's like a standard amount that you want to go off of. So heart failure is usually there's two types. There's HFrEF, which is heart failure with reduced ejection fraction, which makes sense and that's the easiest one to understand. Then there's heart failure with preserved ejection fraction. Now that one's a little harder to understand, but we can just go back to the drawing board and show you why that is the problem. That one, so this is this is just hyperdynamic. This is a high EF. A ballooned out LV will look like that, and now this capacity is too much for it to accomplish these three principles: pressure, volume, and contractility. So this is too much, and this cannot compensate with just contractility, and then your pressure is negligible, so it cannot overcome that weight that's there. So I'm trying to curl a 100-pound dumbbell, and I can't do it. Now, HEF, which is heart failure with preserved ejection fraction, because it's preserved ejection fraction, what's their EF going to be? 55 to 60, but they're still in heart failure. Well, why and how? Let's back to the formula. So their heart, the most common cause of HFrEF, which is diastolic heart failure, HFrEF is systolic heart failure. So what I described before is systolic, diastolic, is what I'm going to describe now. What is the most common cause of that? I taught you this in PD1. Hypertension is the most common cause of diastolic heart failure, or HFpEF. And the reason for that is because you still have your septum, but if you are hypertensive, what does your ventricle have to do? It has to hypertrophy. What happens is your filling volume and your capacity to fill decreases. So you have heart failure, but it's heart failure because your filling capacity is now reduced. It's now beefier. So your pressure may be able to be okay. Your volume is definitely reduced, and your contractility is it usually ends up being reduced because it cannot accomplish what it needs to do, but that contractility is like end-stage diastolic heart failure. So this is like when you go to the gym too much and like you can't even scratch your back. Like you're just all muscle and you can't do anything. Like you're just like everything's just in the way. Like great, but the reason for that is you were doing too much. So there's optimal limits for that. Yeah.
So normal is 55 to 60.
Mm-hmm. Yeah. 50 is considered normal too. Really, the term heart failure comes into play once your ejection fraction falls below 40, right? If you're like 45, it's like you're really on the borderline here. Like you're like early stage heart failure. But if your EF is like 52 or whatever, that's fine. Oh man, that's all I want to talk about EF. So heart failure is a cardiac syndrome that results in inadequate perfusion of tissues and increased tissue and organ water because of what I described. Failure is a clinical syndrome where dysfunction is abnormal mechanical ability. So your heart can have temporary periods where it's not squeezing adequately. What are some diseases that can make the heart not squeeze adequately? Viral syndromes like myocarditis, like it's a temporary thing. Get them through this and then they should be able to recover. We think of heart failure, I want you to think of a chronic, long-term, debilitating disease. But if any of you guys can have acute heart failure, but it's only temporary because of something else. So a lot of people during COVID was getting myocarditis. You had the whole vaccine thing, like young people were getting myocarditis, like it was the thing. And you got them through it, and then they moved on. Some instances of myocarditis can develop as long-term heart failure. So if they don't actually recover, then they're a heart failure patient. So We like to use the term decompensated heart failure whenever we're talking about like an exacerbation or something that they cannot overcome. So systolic heart failure, we're talking about decreased EF, stroke volume, stroke work. Hypertension, ischemic heart disease can cause it, but for diastolic heart failure, hypertension is the most common cause. I know this shouldn't really say hypertension here. Hypertension should be here. Please move that to diastolic. Heart failure with preserved ejection fraction, left ventricle unable to accept adequate volume of blood due to decreased ventricular relaxation or increased ventricular stiffness. Think of this as like an Arnold Schwarzenegger heart. Inability to generate force because it can't actually start the contraction because it's too beefy. Another example is like if you get like a really muscular guy, I'm talking about like these crazy bodybuilders. If you ask any of them to throw a punch, they really can't because they're just all muscle. Like they can't actually get the motion going. So that's kind of the problem with diastolic heart failure. Whereas systolic heart failure, they just can't do anything because they're too weak. It's like an old person, like geriatric punch. So EF is stroke volume over end diastolic volume. Normal range is 55 to 75. But if you see 50, I don't want you to be like, heart failure. No, it's like 45 or less. So that's what HFpEF and HFrEF is. Now, the optimization of these, let's just go through this chart. So HFpEF is going to be preserved ejection fraction, so you can call this / diastolic heart failure. You can call this / systolic heart failure. The boards like to use either one. That's why I'm changing it with you guys regularly because they could use either one. Let's see if this works. So the bigger light's on the ceiling. So that's cool. So we defined these already, right? The phase for HFpEF, diastolic phase. Well, that makes sense because this is diastolic heart failure. Systolic phase. All right, that makes sense too. Ejection fraction. It's preserved. Well, that makes sense because it's greater than 50. It's lower, 45 to 40% is really what the heart failure cutoff is for low EF. So there you go, less than 40. Cause, left ventricular muscles are too stiff for thinking. Arnold Schwarzenegger. Cause, muscles on the left side of the heart do not squeeze properly. So if the most common cause of diastolic heart failure is hypertension, what's the most common cause of systolic heart failure? It's too weak to squeeze. So how do you get weak? You weren't born with heart failure.
MI?
You had an MI, some sort of ischemic event that caused your heart tissue to die. That's why you cannot squeeze properly. Result: left ventricle fails to fill properly with blood because it's too beefy. In systolic, left ventricle fails to pump the amount of blood the body needs because it's weak. Dysfunction: left ventricular diastolic dysfunction, and then in systolic, it's left ventricular systolic dysfunction. So hopefully it's a little easier to understand a little bit of what the principles are. Now, how does it happen? Here's a whole flow sheet of all that, like the renin-angiotensin system and like what happens. So let's try going through this kind of a really busy chart. So MI or myocardial injury is going to lead to reduced cardiac output. It's all about cardiac output. No cardiac output, you're dead. So that will lead to reduced carotid baroreceptor stimulation. Why? Yeah, so it's less pressure because the carotid baroreceptors are coming off what branch of what vessel? Aorta, right? Common carotid, right? Remember your basic anatomy. So that baroreceptor stimulation, and remember how I said yesterday, the kidney, this is like controlling everything. It's also like, hey man, I'm not getting flow. Let's increase the blood pressure. It's like, okay, how do you want to increase the blood pressure? Got it. We'll hold more fluid. That's a terrible idea, but the kidneys can't talk, and that's what happens. So decreased renal perfusion leads to activation of the sympathetic nervous system. It's like, all right, maybe we need some oomph. We'll just secrete some epinephrine. Activation of the renin-aldosterone system. So that, let's go this path. Epinephrine, increased heart rate, inotropy. Great. So now instead of not being able to lift the weight, I'm now just going to go the whole time, and it's like I'm going to get even tired or faster. All right. Increase, and that leads to myocardial toxicity. And it's like your muscles are going to start to tear. It's like, no, I can do this. I can lift this 100-pound dumbbell. Watch me. And you'll just rip everything. And that's going to lead to myocardial toxicity and other issues there. And then you'll have negative remodeling and then worsening LV function, and then you'll put the weight down, for the lack of a better term, which is the end of one beat, and then you'll pick it up again so I can do it again. And you'll just keep shredding this because you can't do it. And that's the symptoms of heart failure. But then if you go to the kidney, that's happening in tandem with the kidney activation. So it's like, I'm not getting perfusion, I need more blood pressure, let's keep more fluid. That's going to lead to more myocardial stretch because you have more volume in that heart. That's going to lead to increased afterload, increased preload, and it's not really going to be able to compensate that. So that's like the physiology of heart failure. How do we treat this? Well, we attack every stage of this flow sheet, of this flow sheet? No, flow chart. In the hospital, when we look at vitals, we call it flow sheet. Flow chart. That's happening there. So the 4 pillars of HFrEF, heart failure with reduced ejection fraction. Now, which one is easier to treat? Systolic heart failure or diastolic? Systolic is harder to treat. Diastolic is hard to treat. How do you fix this? I cannot make your muscle less beefy. It's going to take time. And actually, it's never going to become less beefy. It's just going to stay beefy for almost ever. So that's a problem. But systolic, you're just a wimp, right? You're just weak. So all you got to do is, all right, I can't make you stronger because your muscles died. So all I can do is decrease your weight. I'll just decrease the load that you have to lift with this dumbbell. So you have RNEs, beta blockers, mineralocorticoid antagonists, and SGLT2s. Heard of any of these?
Yeah, SGLT2.
Okay, SGLT2s is like Giardians. These are like your diabetes drugs, but like these are your flozins, like canagliflozins. This has a role in heart failure as well. Although you're like, well, that's a diabetes drug. It actually has a benefit. So the whole hallmark of this is called GDMT, Guideline Directed Medical Therapy. And the hallmark of GDMT is to prevent remodeling. This Schwarzenegger heart is what remodeling is. You don't want that to happen. A dilated and a ballooned out LV, that's remodeling. You're trying to reduce remodeling because once muscles remodel, it's not going to get fixed again. So, SGLT, these all have benefits within 30 days of treatment, but they're not always able to be used. So, like, these people have to be like in the community and like walking, talking for the stuff to use. If they're hospitalized, well, they're probably in an exacerbation or a decompensated state. And a lot of these have side effects. If I put someone on a beta blocker, what's going to happen to their heart rate?
Slow it down.
All right, that might be good. Maybe they don't need to have, pump as much. Okay. What's the other side effect of that?
Bradycardia.
Low blood pressure. Remember, cardiac, it's like a fine balance. So in the inpatient setting, we might start this and we may either A, tolerate a lower blood pressure. We might say if their systolic blood pressure is like 85 or above, we're okay with this. Or you might say, yeah, you just can't handle it. It's just too much for you right now. Angiotensin receptor antagonist, I don't forget what the N is. It's like some weird protein. These are your ACEs and ARBs. That'll help with the renal perfusion. That'll help with remodeling as well. Mineralocorticoid antagonist, this is going to be like your aldactone, which is your potassium-sparing diuretic. You ought to be aware of clinical stagnation, which is like you can start them on this therapy, but like this thing is constantly changing, so you want to be updated with the latest guidelines for that. And if they're on it for a protracted period of time, it sometimes loses its efficacy, but it's the best we got right now. Now, what if someone has really bad end-stage heart failure? Like they have this heart failure, they're like young. What's young in medicine? Young is like 60. Oh, yeah. 55, 60 is a young person. I know you guys are all really young, so like to you as like an ancient, that's a young person. 55 to 60, if you can get them 20, 30 more years of life, like that's then you're hitting life expectancy. 60, depends on their other past medical history. If they're like a good 6-year-old, no medical issues, that's a great 60. Some even say like 70 is young, but that's kind of pushing. But it depends on what kind of 70 we're talking about. You can have 70 like decrepit, and then you can have 70 like they're running marathons. So it depends. They're probably not winning, but they're running. So what do you do for them? You're doing all this GDMT and all this stuff, but it's not cutting it. They used to run marathons. They don't run marathons. What do they need?
Stent.
Huh?
Stent.
What does a stent fix from one of the first slides? Who puts a stent in? You have a clogged toilet. Who are you calling? Okay, so what's that going to do? It's going to help the toilet flush better. Is that going to fix everything? It's a muscle problem. It's a structure problem. Your pipes are clogged. You call interventional cardiologist. Your pipes are old and destroyed. You need a different type of plumber. It's a much bigger job, right? What someone say? Transplant. You need a new heart. It's shot. It's not going to work. You'll need a heart transplant. That's like reserved for like certain circumstances. You have to go to a center that does heart transplants. It's like a whole thing, get vetted and everything else. Because they don't want to give a heart just to be wasted, right? It's a reserved, valuable resources. Okay, left-sided heart failure. Failure of the left side to pump sufficient blood. So another thing for this is systolic heart failure, or HFrEF. Backs up into the pulmonary circulation and increases pulmonary pressure, which makes sense. We talked about this in PD1. You mess up anything in the circulation, and it's going to back up. Most common cause is ischemic heart disease. Hypertension can also cause it. Mitral or aortic valve disease is also very common. The most common valvular anomaly, or the most common valvular pathology worldwide is mitral regurg. Who told you aortic stenosis? Huh? Oh, you guessing? Okay, it's mitral regurg.
I think they said like it was most you'll see in like.
No, yeah, worldwide. Yeah, it's mitral regurg.
Yeah. Oh, some pants. That's what it's from.
Cram the pants.
Yeah, it's like a podcast. He was like, "Oh, when I go to clinical, I just said aortic stenosis."
I was right.
Most common what you see.
I mean, I see more aortic stenosis than mitral regurg, but worldwide it is mitral regurg. I'm pretty sure. I have to double.
You never heard of cram pants?
These things didn't exist when I was a student, and I don't look into them now.
That is. Not secure.
The aortic's most common in developed countries, but mitral is more common worldwide. I guess we're both right. Kind of, but worldwide. Worldwide. Regurg. I said which valve is affected, but yeah, regurg or what the hell? Swap. Come on. Right side heart failure. All right. So right side heart failure is a hard topic to understand well. You may think you know it's a very easy topic to understand superficially. It leads to hypertrophy and a dilated heart. What can cause right-sided heart failure? What? Left-sided heart failure, yes. To understand what causes right-sided heart failure, you need to understand the causes of pulmonary hypertension. If you understand the causes of pulmonary hypertension, they all end up leading to right-sided heart failure, and then it just makes the whole thing easier. So, what can cause it? Diffuse hypoxic pulmonary disease is the most common. But so left-sided heart failure is most common. That's a bad bullet point. Left ventricular filling pressure that is reflected back into pulmonary circulation, which is left-sided heart failure. This is really poorly written. I didn't make this particular slide. Other causes: lung disease, tricuspid, or any valvular disease, congenital heart disease, or cor pulmonale. Did you guys do tau warrior?
No, we have
Tonight.
today.
Oh, nice. First time?
Yeah. Is he always on Zoom?
So cor pulmonale is end stage right ventricular right ventricle failure. Oh man, why not have it? That's sad. Well, that's sad. Huh. All right.
There's paper.
What?
Paper. Clean.
What do I do with paper?
Clean it.
I mean, that's good. Not as ergonomic. All right. To understand right center heart failure well, you should understand pulmonary hypertension. Pulmonary hypertension. Al War is like a world-renowned expert on pulmonary hypertension, so this is going to be like child's play to him. But pulmonary hypertension is going to be increased pressure in pulmonary artery, or the most common. And then the way the cause of pulmonary hypertension are divided into groups. There's 5 groups. So group 1, pulmonary hypertension. Pulmonary hypertension is defined as,
Increased pressure in the pulse.
that's what group 1 pulmonary hypertension is. Increased, it's called pulmonary arterial hypertension. The pulmonary artery is just constricted, beefed up, and as a result, you're ending up with high PA pressures. But hold on, let's take a step back. What are normal PA pressures? 40. Play the price is right. 40, what else we got?
5 to 10.
5 to 10. 50.
45.
Okay. Now let's use our brains. So the pulmonary vasculature has to do with right side of the heart. Right side of the heart is generally venous blood, so pressure is probably on that Starling curve. Thing drops to around 5 to 20. Then it goes up to the left side, right? So it's around. Normal pressures are normally around, 10 to like 20. Systolic, and around like 5 to like 10 diastolic. Generally. So pulmonary arterial hypertension is, the pulmonary artery pressure is like high. It's like 30, 40, 50. So why is it high? What are the groups? What group pulmonary hypertension is this patient? Say, oh, it's group 1. Nothing you can do about it. The arteries are just beefy, is what it is. All right. Group 2. So group 1 is the definition. Group 2, well, I told you that pulmonary hypertension is another way of getting to,
Right center heart.
the most common cause of right center heart failure is,
Left side.
all right, so group 2 is left side heart failure. Or CHF, whatever you want to call it. All right. Group 3, word 3 rhymes with the disease, COPD. So group 3 is pulmonary diseases. That's COPD. Group 4 is called CTEPH, which stands for chronic thromboembolism pulmonary hypertension. What the hell does that mean? Well, that means a chronic thromboembolism. So when I say thromboembolism, you're thinking what? PE, bigger. So PE sits in the pulmonary trunk, right? Pulmonary vasculature, and you have a clot. And then, depending on the severity of the clot, it may or may not kill you. But you can have a PE and live, right? It'll be fine. Well, you find it. And what do we treat this with? What's the hallmark of treatment for all PEs? No, not
Anticoagulation.
TPA. TPA is only for unstable PEs that are just going to kill you.
Anticoagulation.
Anticoagulation. Now, what's the purpose of anticoagulation? What?
Prevent it from getting bigger
Prevent it from getting bigger,
and breaking or
prevent new clots. It is not going to definitively get rid of this clot. It may trim it a little bit, but it's still there. And this becomes like cement afterwards, and it stays there. And the pulmonary artery is in the business of pumping things. Now, basically, what you got is a big clog here for life, and it cannot adequately come over this unless it increases the pressure. So it gets bigger, and then you have more flow to then go around that clot and go perfuse the lungs. So that's what chronic thromboembolism pulmonary hypertension is. You end up with that because you have that clot there. So when we give TPA, we're giving it because it's going to kill them, but it's also going to reduce. This is called remodeling. You change the size of it. It'll reduce remodeling. Another thing that we give that's alternatives for TPA is you can do thrombectomy. You can take the clot out, prevents remodeling. So you can put someone on heparin, like you're fine, but like they will end up with pulmonary hypertension in like 20 years, 15 to 20 years, maybe sooner, depending if the clot's larger. So that's CTEP. And group 5. What's group 5? Who knows? Anybody? Yeah, no one does. Because it's idiopathic. Idiopathic, or it doesn't otherwise fit better in the other categories, like sarcoid. It doesn't fit anywhere else. It's not the definition. It's not hard. It's not smoking. It's not CTEF. Put it in group 5. That's the 5 types of pulmonary hypertension, 5 groups of pulmonary hypertension. And this will then lead to hypertrophied pulmonary vessel, pulmonary artery, will then lead to, if this gets really big and the pressures are high, well, what's going to happen? You're now achieving a principle of afterload, right? Now you're achieving like pulmonary vascular afterload. So now that has to back up into the RV. So you will end up with a dilated RV, and the RV does very poorly with high pressures. Remember that from PE. It sucks with high pressures. So your key is to treat pulmonary hypertension. Now, which one of these was actually a problem with the pulmonary artery? Just the first one. So the only one that you can treat as treating pulmonary hypertension is only group 1. Is only if your vessel's beefed up. So I can give you a medication that'll make your vessel not beefed. But if I give you a medication to make your vessel not beefed and you have left-sided heart failure, I'm just going to put you in exacerbation because that's the reason why you're in pulmonary hypertension, right-sided heart failure. If I give you that medication to make you less beefed and because you have end-stage COPD, it's beef because it's trying to survive. If I hamper that, that's like giving someone a beta blocker if they're sinus tachy. Do you ever treat sinus tachycardia? You never treat sinus tachycardia because sinus tachycardia is sinus. It's coming from the SA node, which means it's normal. So if someone is sinus tachy, your first question, how do you treat sinus tachycardia, is you treat the underlying cause. Why are they tachy? So if somebody is sinus tachy, for example, you're hemorrhaging. I hope you're sinus tachy because then that's your heart rate is going up to compensate for cardiac output. So I had a GI doctor come once, young guy, hemorrhaging. We call him Dr. No Scope. He doesn't want to scope anybody. And he's like, hey man, you want to scope this guy? He's real tacky. Yeah, no shit. So like, okay. And then he's like, can you give him something to drop his heart rate that I can get anesthesia to do it? I was like, yeah, cool. You want me to kill his compensation? knock it down, right? Because if cardiac output is heart rate times stroke volume, and your stroke volume is low because you're bleeding, then your heart rate has to be high. And if you're young, it's going to be doing fast. So that's going to make this happy. And he's like, and people treat numbers. Oh, he's sinus tapped to the 130s, 140s. And it's like, okay, it's sinus. It's like, no, give him a beta blocker. And some people will. And nurses will call you saying, hey, patient's tachy, 125. You want to give some metoprolol? And you're going to be new. And they're like, yeah, that sounds good. And then you give them the beta blocker. That'll then make the heart rate, no matter how hard it wants to try, it's like, nope, you're blocked. You cannot go fast. Well, it was only high for a reason, so now cardiac output goes down. And the nurse called saying, hey, yeah, now his blood pressure dropped. It must have been the metoprolol. The vasodilation of the metoprolol probably did it. No, it's the beta blockade of the metoprolol that did it. You just literally had someone that was swimming with one arm because the other arm is broken for whatever reason, and you broke their other arm. That's what you did. They will sink now. So if you how do I get on this? Sinus tachy.
Treating group 1.
You can only treat group 1.
Group 1,
Oh, yeah. So, like, if you treat, it basically is the same principle. So, group 1, there's a drug for this that treats group 1 pulmonary hypertension. What's the only pulmonary hypertension drug that you guys know?
Oh, the ED meds.
Yeah.
Viagra, Cialis.
Sildenafil.
Yeah, there you go.
Viagra. It's the only pulmonary hypertension drug. You guys know the history of sildenafil, right?
Yes, it was an accident.
Yes. So that's the only one that. So you're not going to use that on these other ones because this is going to treat. Beta blockers have a role, right? If you're tachy for AFib, good, control the heart rate. If you're hypertensive because you're vasoconstricted, good, vasodilate. There's a reason for it. But if I give you this drug and you have these issues, that's me breaking your other arm. You understand? So you have to treat the underlying cause. You have to fix the other arm instead of breaking this one. So instead of, if this one's down and in that young GI bleeder, me breaking his arm, the correct thing is, hey doc, why don't you fix his bleed? And then the heart rate will come down on its own. So I had to tell him that. That was kind of awkward. I was like, all right, just to clarify, you want me to remove his compensation mechanism and reduce his sinus tachycardia and reduce his cardiac output? I just want to clarify. And then he said, look at reduce scope. That's not going to go. So anyway, so how do you treat right-sided heart failure? Well, it depends. If left-sided heart failure, fix that first. Optimize that with GDMT. Can they get diuretics? Can you reduce the preload? Can you give them medication to reduce that? Oh, it's from end-stage COPD. All right, treat their COPD. If it's from CTAP, all right, can you get rid of the clot? This is like after. You can actually get the endarterectomy years later. You can do it. And then it's group 5. Well, that sucks because we don't really know how to treat that. Or it's sarcoids, autoimmune. Give them steroids, see what happens. But that's really pulmonary hypertension. So that is really what right-sided heart failure is. So let's go back to this. Hypertrophy and dilated heart causes diffuse hypoxic pulmonary disease, which is going to be group 3, but left-sided heart failure is the most common cause. Intrinsic lung disease, group 3. Pulmonary tricuspid valve disease, group 2, heart failure. Congenital heart disease, group 2, heart failure. And that can lead to cor pulmonale, PE, group 4. So it's all sprinkled in there as the causes of pulmonary hypertension. So cor pulmonale is end-stage right-sided heart failure. Right ventricular hypertrophy, it's dilated, causes pulmonary hypertension from primary lung disease or pulmonary vascular disorders, a big PE, CTEPH. Chronic group 3, pulmonary hypertension, group 1. Right ventricular, it makes sense now. It's all the types of pulmonary hypertension is really what right-sided heart failure is. LV hypertrophy, or really hypertrophy in genesis, is going to be increased pressure or volume that causes increased work. So it's either going to balloon out like a wimp, or it's going to come up and beef up, but that's going to reduce your filling capacity. It'll lead to increased cell size and function. Prolonged hypertrophy can lead to contractile dysfunction like diastolic heart failure. There's volume overload and pressure overload to the concentric or eccentric. Pressure overload is going to be concentric and volume overload is eccentric. So this is eccentric, that's concentric. Makes sense. I hate it. It's such a complicated topic. It's not easy to understand. There's so many caveats to it. Yeah.
So could you go from ref and then go to pet later on?
Yeah, you're saying, so you're assuming what?
Like, so now it's wimpy because of the hypertension.
No,
and
what,
then-
well, what do we accomplish in your example?
oh,
You said ref
yeah.
and then go to pep. So you went from low EF to high EF. So what did we accomplish? Recovery, right? How do we accomplish recovery? I told you whatever's dead is dead. How? You're almost there. The meds we gave optimized them. The GDMT worked. Now you've improved their EF. So you've kind of stabilized them. Yeah, so you can with therapy. Drug therapy. That answer your question?
But pet is not what we're looking for.
It's not
We
what we're
wouldn't go into
Well, okay, I see what you're saying. So is ref is the yeah. Okay, I kind of see what you mean, but they still have heart failure. Like that's not going away.
Okay.
It's chronic. So it is kind of HEF,
right.
but it's like pharmacologically imposed, if you would. If you're hypotensive, what do I have to give you?
Yeah,
Right, it's called pressor. So your blood pressure off at pressors is 70 systolic. Your family walks in the room. Oh wow, you guys fixed him. 120 over 80. Okay, he's on rocket fuel. I have him on like 3 pressors. So is your blood pressure normal? Right now it is. But it's with support. So are you still in shock? Yeah, because you're requiring medication. So is that kind of so it's still there.
Okay.
It doesn't really go away. But then one thing I want to go over the heart failure again is exacerbation. So like, and I talked about this in PD1, like people can be on heart failure and be on GDMT and live their life. But what puts them in the hospital? This concept is key to understand in medicine. No. Huh? Any increase in demand. It's a now you see when I was talking, kind of need to understand there. It's a delicate balance. I'm just like, all right, heart's good, blood pressure's okay, beta block is okay. All right, cool. But anything that increases metabolic demand. So what can increase metabolic demand? Illness. They're sick. You're infected. You have acute inflammation. You have the immune cascade going on. You have interleukin-1, tumor necrosis factor alpha. You got a fever. What's the most common vital sign change with a fever? Besides the temperature. Tachycardia. Oh, crap. Why are you tachy? That's why you treat the underlying cause. Should I give you a beta blocker to fix the tachycardia? And just let whatever infection, meanwhile they have a UTI, you're just letting it proliferate. Then it's going higher, it's going to pyelo. Shit, now they're septic. Now they're septic, their blood pressure's low. Now the blood pressure's low, I can't give them any of this crap. And now their kidney's failing, it's not getting flow. Now I can't use ACEs anymore. It's just all connected. So any sort of chronic disease, what are chronic debilitating diseases? COPD, heart failure, diabetes, anything that will increase metabolic demand will put them into an exacerbation. So a heart failure exacerbation is everything falls off the rails and it goes into end stage. So it's going to back up into the lungs. They're not going to be able to breathe. They're going to be short of breath. End stage COPD is going to have lung problems. They're going to be deep hypoxic. Heart failure will make them hypoxic too, but for other reasons. It's not a lung problem. They're just drowning. What's a diabetes exacerbation? DKA, diabetic ketoacidosis, right? What do we assume is the most common? When someone comes in with DKA, what do we assume of them?
Type 1.
Yeah, but how this happened?
not complying with their.
Most people think that they're bums and they're not taking their medication. Oh, you're eating Snickers, or oh, they weren't compliant. And sometimes that is true, but sometimes like no, I did everything right. Like I'm a school teacher. I have my pump. I have my Dexcom. I don't know what happened. I just feel like crap. And then you have to work up for an infection because something else happened. It wasn't non-compliance. Oh, you actually have tested positive for rhinovirus. You have a cold, and that told your body, hey, I need more glucose. Or if you have heart failure, hey, I need more cardiac output. It's like, whoa, I can barely do the cardiac output that I need to just live. It's like, well, I need more. It's like, well, I can't do it. Okay, I'm still gonna ask for it, and it's gonna take it, and you're gonna exacerbate, and that's where you end up like end stage. So any exacerbation is an increase in metabolic demand. Infection. Hey, I want to go run. Awful idea. But then they do it, and then it's increase in metabolic demand. Make sure your heart is safe enough for sexual activity. Talk with your provider. That's what that is, right? That's also physical activity. So any increase in metabolic demand can cause this stuff to happen. Does that make sense? So that's how you end up with a heart failure exacerbation. So you don't. So if things are good, things are good. You're fine. You're okay. You know, maybe your patient like maybe I overdid it. You know, I had company visiting us, and they wanted to go to the city, and I usually only walk a couple of blocks, but you know, I walked a lot yesterday, and I got really tired, and I really couldn't catch my breath again. Well, you increase your metabolic demand. You basically had a stress test that failed. But if you asked me, I would have just told you not to do that. You're going to fail anyway because, well, your heart sucks. Here's a good chart that describes like different types of like heart failure and stuff. It's kind of like that chart I had in PD1 with the 4 things. It's just like more wordiness of it. All right, I guess. So the preserved ejection fraction is going to be half. Hypertensive heart disease, most common cause. You can also have restrictive cardiomyopathy, which is like amyloidosis, or hypertrophic cardiomyopathy, which can be like the Schwarzenegger heart. But we keep saying Schwarzenegger heart is from hypertension, but you can have Schwarzenegger heart with my own term. You can have that with young athlete exercising a lot. And they're exercising a lot because they have no idea they have a structural issue because we don't screen kids with echoes, and they may have an LV inflow tract obstruction, or they may have HOCM, or they may have IHSS. You know, they have other structural things that they're born with. They're working out that all of a sudden, like, yeah, your heart's destroyed. And it's like a young person, usually African Americans, actually. They have more commonly to get the collagen vascular stuff, and they're generally more athletic. And then it's like, yeah, your heart's messed up. It's like, what are you talking about? I'm like 28 years old. I'm like at the peak. It's like, yeah, no. I don't know what to tell you, but your LV's ballooned out. Those are the ones that get transplants. So these are the 2 different types of diastolic heart failure. So echo shows preserved ejection fraction with increased LV wall thickness. There's echocardiogram shows preserved ejection fraction with normal LV wall thickness. These ones are like reversible to a degree, but either one of these can end up requiring a transplant. There are how SGLT2s actually work at the oxidative level. Anyway, atherosclerosis. So the rest of the stuff should kind of make sense. This should hopefully be reviewed. Atherosclerosis, a lot of cholesterol, progressive accumulation of inflammatory cells. You have large and medium arteries that get affected. You eat a lot of McDonald's, you'll end up with a heart attack. Here's what happens. This fatty deposition actually fills in those areas, and eventually it will violate the basement membrane and rupture. And then you got an MI, and that's really what that is, atherosclerotic rupture. That's what they call it. So risk factors is you can't modify as age. The older you get, higher risk. Gender, which gender is more affected with MIs? Male. Until menopause. Good. Family history. Sometimes you have your patient that comes with the MI at 35. It's like, yeah, my dad dropped dead at 35, 38. My grandpa did too. Like, it's probably going to happen with this one as well. Things you can modify and control is your cholesterol, hypertension, whether they smoke or not, or diabetes. Now, you can't control if you get diabetes, but you can control if you maintain your diabetes. Obesity, physical inactivity, stress, and postmenopausal estrogen deficiency. I don't know if that's controllable. It is, but well, you can do hormone replacement therapy, which is all the rage in the 80s and 90s, but then they said that that causes breast cancer. And then there was a study like this year that says it's not anymore, which is crazy. Um, so there's different theories of how MIs and everything else occurs. You get your increase. The typical ones you're learning right now is, too much LDL, bad cholesterol, leads to accumulation in the arteries, and then you want to reduce your LDL and increase your HDL, which will then clear some of the LDL, and you want to gonna have better, less fatty streaks, less atherosclerotic disease, and that'll improve. Monocyte migration, injury to that area leads to platelet adhesion, that leads to clots, and that can lead to other lipids accumulating. Those clots can rupture. The clots can cause occlusions and cause narrowing, like it's bleeding a little bit in the vessel, and then it clots up, and now your vessel is narrowed. So instead of having this much vessel for blood to flow through, let's say there's a little bit of injury here with a fatty streak or something, and now I'm going to use this as my clot. Well, now it's narrower because now it has to go around this. And that is what leads to ischemia. It's like, they're having activity, they're running, they're playing with their kids. Like, my chest hurts. And they sit down, and it gets a little better because they don't require as much cardiac output. So it improves, right? That's what angina is. And then if it gets too much and it goes over, where the heart is like, I need more oxygen and it can't provide it, then that's how you develop an MI. But we're not sure. There's like new theories right now of like how the LDL actually works and everything. So still learn this, but be on the lookout for this in the future of your career. So MI is going to be disruption of the plaques. It's going to be exposure to the subendothelium. The basement membrane has been violated, and all those necrotic contents are circulating. So you're in a high inflammatory state. Platelets are going to come and try to clot, fix the rupture from the atherosclerotic rupture, and that leads to more narrowing. It's a self-fulfilling thing. Vasospasm, you have loss of function. So stable plaque leads to stable angina, but eventually once that ruptures, platelets are going to come, plug the hole, but that in turn will lead to reduced flow. So your vessel and here's McDonald's. Years of Big Macs. So then your vessel will have that and it'll grow over it. But eventually there'll be a sale one day, buy one, get 2 Big Macs free. You couldn't resist. So you get more Big Macs and eventually it'll rupture through. And now when it ruptures through, your body's going to be, my vessel has a rupture in it. First thing I'm going to do is I'm going to plug that hole. But depending on how big it is, or big MI, is going to be how much clot it actually needs. But remember, this is coronary vasculature. This is what you need to live. So what happens is, eventually, you may have impaired flow and only very little blood is getting through. And that's why you feel like you're dying. This is also why you don't drop dead. Like some blood goes through. Whereas if you go back to the McDonald's thing, before it ruptures, if this is all McDonald's and this is the atherosclerotic, your same principle. This is angina. Instead of it's gonna be only a small amount of blood that can get through, and eventually that will get you. Which is why it says, I just don't feel good, and they're usually overweight and everything, and then that happens. So that's atherosclerotic heart disease. Now, there's other reasons for MI as well. It's not just being fat. Like the 30-year-old, 35-year-old has an MI. They're usually young, man. They're usually okay. So we got different types of MI. Oh, that's this. I was going with this. But then unstable plaque with ulceration, rupture, and thrombosis. So then you have clots. That leads to acute coronary syndrome, and it can be sustained, which leads to infarction, which leads to inflammation and necrosis. And then it can be transient ischemia, which can be like unstable angina, which is defined as what? Unstable angina.
Acute coronary syndrome.
It's a type of acute coronary syndrome, but what is it exactly? Pain at rest, discomfort at rest. Angina, you're playing with your kids, chest hurts, I'm getting too over this, sit down, you feel better. Unstable angina, playing with your kids, I'm getting too over this, sit down, you're still not better. Get some water, relax, still not better. Unstable angina, that's pain at rest. So that can happen for a long term, and this is kind of what unstable angina will look like. You just have too much cholesterol and everything else that's blocking that area. Push it enough leads to MI. And that can lead to stunned myocytes, hibernating myocytes, and myocardial remodeling. You can have a large MI, get a cabbage, right, or open heart surgery, and then your heart will just like be stunned for a period of time, maybe days or weeks, or just like not cooperating. Not weeks, days, hours to days, where it's not cooperating. After you fix, I fixed it. I fixed your flow. Everything was good, but the heart's just not cooperating for a period of time because it's trying to recover. It had a big catastrophic event. So MIs or troponin, there's 5 types of troponin, and you should know this slide. You should also know that pulmonary hypertension one. If you want, you can just Google pulmonary hypertension groups, and it's the same thing I just threw out. Probably more wordy. But 5 types of pulmonary hypertension, 5 types of troponin. That's nice. So type 1 is your typical troponin, spontaneous related to primary atherosclerotic event, or an atherosclerotic rupture. It ruptures, you have a giant MI. That's what that is. Too much Big Mac. You guys ever watch? You guys watch?
Super Sesame?
Oh no, Fresh Prince.
Yeah.
Bel Air?
Yeah.
No.
Yeah. You guys see the one where like Uncle Phil is like home by himself and he gets a bunch of burgers for himself and he starts eating them and he has a giant MI? That's type 1. Type 2, and this often will be, you guys are going to be trained like, oh, any troponin elevation, call cardiology. And then you're going to be the cardio PA. And you're getting so many calls for troponin. And not the whole world is not having an MI. But you're going to be like, all right, what's going on? Oh, my patient's here for UTI. They're older. They have some heart failure. And the troponin is elevated. All right, how high is the troponin? It's 1. And it's like, okay, did you repeat it? And it's like, yeah, the repeat is 1.1. Okay. We will see the patient. Then you'll be like, oh, you get an echo, you get EKG, you get, whatever else you need. You may anticoagulate them for 48 hours, which is the treatment of medical management MI. So not every MI goes to the cath lab. Or it'll be like, hey, when I call them, hey man, so my patient's got elevated trope. So what is it? I'm like, it's like 1. And it's like, okay. Did you repeat it? Well, that is the repeat. The previous one was 15. So you're supposed to repeat troponin. So if you have an MI, right, if you have something that's causing it, well, is it going to get better? No, it keeps climbing up. So the way you do it, you do whatever you want to do when you get trained, but you get your first troponin, whoop-de-doo. Unless it's like 1,000, like, yeah, this is the problem, you always repeat it. And if it gets better, that means that whatever caused it is being reversed. So they call that demand ischemia. I would know that term, demand ischemia. It's called a type 2 MI. So if you have, I don't know, pneumonia, really bad pneumonia, and you have heart failure with it, right? Your heart's going to work hard. And troponin, if you look back at yesterday's slides, is a protein that's secreted when your heart's under stress. So you're going to have a little troponin. And if you're fixing the underlying cause of the pneumonia or their heart failure, it should go down. But if it continues to rise, could it be an MI? Could be. Could it be demand? Could be. You want to take that chance? Nope. I'm going to call cardiology and say, discuss with cardiology recommended X, Y, and Z. And that's fine. what can sometimes happen is you repeat it's like 1, repeats at 1.5, next one's like 2, and the next one's like 30,000. Like that happens. So you keep trending troponin until it peaks, and then once it drops, you can stop trending it. But otherwise, you keep trending until it peaks, and it's for that reason, because the most common diagnosis missed in the hospital is NSTEMI, non-ST elevation MI. So you need to take it seriously, and it's annoying for cardiology, but I didn't tell them to become a cardio PA. It is what they chose that life. So that's what a type 2 MI is. It's demand ischemia. Demand, asking more of the heart, ischemia. Troponin elevation is ischemia. No matter which way you slice it, it shouldn't be there. But something is causing that. But it's not necessarily mean that they're having a massive MI. You see the difference? Type 1, will the troponin be on a true MI? Well, either A, they'll have crazy chest pain and crazy EKG findings, or B, their troponin will be like 1,000 or like 500, very high. Type 3 is only found on autopsy. That's called SCAD, sudden coronary artery dissection. This is when you're just sitting there and your coronary artery randomly just dissects, and you just drop dead randomly. Most common in college-educated females. I don't know why.
What was the other thing that's like, only educated?
Yeah. You guys got estrogen going for you, so you got that.
Yeah.
So, SCAD, artery dissection, younger women, more common. Type 4 MI is going to be the MI you see after a stent. So all troponin is your heart spilling protein. So if I go and you call the plumber and he's digging through your pipes, well, it's going to spill some protein because it probably scraped some of the walls, because how else are you going to get the clot out? So that's why you don't check troponins after a stent, because, well, we know it's going to be high, right? It's like having a PE diagnosed on CT and then saying, I'm going to get a D-dimer. It's like, for what? You already know there's a clot there. So why would you get a troponin? Because you're going to get the troponin and be, hey, cardiology, troponin's elevated. It's like, yeah, no shit, idiot. I just went through plumbing through their arteries. Who's your attending? Why are you training troponins on my patients? Stop doing that. And it's like, and the young person will be like, well, it's elevated though. Like, it shouldn't be elevated. And then they go back to school. This happens. These are real scenarios. Type 5 MI is the MI that happens after a cabbage. Now, these are like 50,000, 100,000 troponin, which makes sense because they literally cut the heart and are literally doing surgery on it. So that makes sense. So we also don't trend troponins after a cabbage generally. AMI is acute MI and CMI is chronic myocardial injury. So demand ischemia type 2. So this is an important chart to all the different types of troponin. So if you see a troponin, you should ask yourself, what type is it? Type 1, I'm calling cardio. Type 3, you read it in the newspaper. Type 4 and 5, who ordered these troponins? And you have to look at the whole scenario. Now, if you had a patient with a cabbage and he's awake and he's like, I have excruciating chest pain. I feel like I'm dying. You take that seriously, and you do get a troponin because you have a good reason. He's literally screaming for help because what is a cabbage? They take a vessel, a coronary artery bypass graft. They take a graft, either radial artery or saphenous vein, and they anastomose it to the aorta and give the heart flow. Well, what can happen to that vessel? When they had the MI, what happened to their vessel? It clogged. The new one can clog also. You understand? So you don't generally get them on these scenarios, but there are circumstances where you will, where all of a sudden, like, they fixed you. You should be like recovering very quickly. And it's like they're getting much worse, much faster. And it's like, oh crap, I think they have graft occlusion. Here's more MI stuff, MI diagnosis. So this is the whole thing I was drawing out there. This is McDonald's. The demand ischemia. You'll have no ST segment elevation in the end STEMI, and it can eventually lead to MI. And this is that plaque ruptured, the clot formed, and it clogged off the whole flow. So you have MI. This is your STEMI. Okay. You guys know this stuff, right? I'm not gonna like beat this into his turn. All right. Coronary circulation, you got your main coronary vessels, your left coronary artery, and your left coronary artery and your right coronary artery. Your right coronary artery supplies what?
Right.
Yeah, right ventricle. Yeah, nice. What else does supply? Yeah, not 1, 2.
2, 3.
2, 3 and AVF. Yeah, AV foot. Bottom. Okay, yeah. So if I have a right-sided MI or a right coronary artery MI, I'll present with the typical symptoms. Plus, what will my heart rate be? Huh?
And then back the essay.
Is the SA node perfused by the right coronary artery? Yes. So what's my heart rate going to be?
Low.
I might be really low. I might be in heart block because I knocked out my SA node and my AV node. So, am I perfusing well? What's your body's typical response to not perfusing well? Increase the heart rate. Oh, damn. SA node is not working. You're in complete heart block. Highest heart rate you can get on complete heart block is? Yeah, 20, 40 in the middle is like 30. Your heart rate's 30 and you're having a massive MI.
Nice.
You're not going to do well. That's what I call the widowmaker. It happens quick. And like they just can't compensate and they just drop dead because they can't have forward flow, no cardiac output. No cardiac output, and it's a problem. So if it's a right-sided MI, it's affecting the conduction system. Left-sided MI is affecting the LV. Is that better or worse? Well, I don't know. Which ventricle is more important? The LV. So would you rather be Brady and having an MI or not having an LV?
Yeah.
Yeah. You want to get shot on this side of your head or this side? It's not a great option. It's just like whatever you want to do. But you have to recognize that. You say, all right, oh, this is an inferior MI, 2, 3 AVF. I'm going to call cardiology and everything else. And it's like, wait, this guy can go into heart block. And you have to recognize that, be aware. They're not all going to go into heart block, but you have to be vigilant about it and treat it urgently. Or maybe they went into heart block, but they're not behaving like an MI. What if they're just Brady? It's like, huh? That's why you always have to ask the question, why? Why are they in heart block? Did they knock out the RCA? Is there a lack of flow there? Oh, yeah, I'm saying to the cath lab. Actually, yeah, he does have an occlusion here in the RCA. So he's not getting flow to the SA node. So he's in heart block because of that. He just missed the giant MI. Good catch. You understand? It goes both ways. Coronary artery disease. Okay, we did this already. Angina, intermittent chest pain caused by reversible ischemia. We explained this already. Typical and stable is going to be getting better with rest after oxygen demand decreases. Unstable is not going to improve with rest. It's new, different. Then there's Prince metal angina, which is coronary artery vasospasm. You have the vessels there. They're good, but they're actually spasming. To treat any vascular vasospasm, you treat it with calcium channel blockers, specifically non-DHP calcium, DHP calcium channel blockers like amlodipine, nifedipine, cardine, DHPs is what you want to use. Then there's nimodipine. If it's like, you can also have vasospasm in your brain, like subarachnoid and stuff. MI, heart attack, Levine sign, males, smokers. We know this. What's a Q wave? Yeah, it's an old MI. It's a deep Q wave. That means like it's old. They may end up with arrhythmia after an MI, which makes sense because it depends if you affected their SA node. Is it on the right side? Could it be right and left? Yeah. Could it be right and septal? Yeah. Depends on where it is. So arrhythmias is often common. And going back to heart failure, if you have an ejection fraction of 20% or less, you bought yourself an AICD, which is a defibrillator or a pacemaker device. Does anyone know why? What was the question? If your ejection fraction is less 20% or less, or 25% or less, you bought yourself a cardiac device, a defibrillator or a pacemaker. Why?
Oh, is it because you could go out of normal rhythm?
you can end up in VTAC. Why?
You're not perfusing your SE.
You're not perfusing your SA node. You are at high risk because your EF is low. You will need a pacemaker, or you need an AICD is what you need, which is an internal cardiac defibrillator. It will shock you out of your malignant arrhythmia. A pacemaker just keeps your heart rate. So a heart block is all you need is a pacemaker. AICD shocks. So if you're prone to malignant arrhythmias, you need an AICD. Sometimes you end up with a crazy MI, and you get an echo after they fix you, or maybe they can't fix you. It's too far gone. You already made Q waves. Now your EF is 15. What'd you buy? An AICD. Oh, I had a really bad heart. And then if someone has an AICD, you just look at the X-ray and you see it. You're like, all right. Automatically, I know this guy's heart shot. For whatever reason, I didn't even meet this guy yet. I was looking at his X-ray. It's like, yeah, shot heart. And you ask them, and this is when you become a better clinician. You ask them, and some of your preceptors will do this, like, so did you have a heart attack before? And it's like, the ER doesn't have any past medical history, and it's like, yeah, I did. And it's like, oh, how'd you know that? It's like, because he has an AIC, he shouldn't have it, right? Or if he has just a pacemaker, and you're like, so what what problem did you have with your heart? You got a pacemaker. Oh yeah, I had really bad line. Which ends up a third of your heart block. So you kind of connect the dots and figure out why things are. Healthy people that go get a cabbage, that do well, they get a PCI, they don't get pacers or AICDs unless something is wrong. That's what this is coming from. Risk of arrhythmia or heart failure. Complications of MI are going to be like contractile dysfunction, which makes sense, arrhythmia, you can have sudden death, mural thrombus, which we talked about. You can also have tamponade, which is blood around the ventricles, congestive heart failure, pericarditis, aneurysm, very bad. This is a weakening of arterial wall. We talked about this in lecture 4. There's pseudoaneurysms and true aneurysms. True aneurysm is going to affect all 3 layers, whereas a pseudoaneurysm will only be 1 or 2 of the layers. Blood can bleed out, and this is a pseudoaneurysm over here, because if you look at the adventitia, it's just only there to hold the blood, whereas a true aneurysm is like the adventitia is bowed with it, and there's really nothing else causing it. So pseudoaneurysm is a very common cause in interventional procedures. So if I stick a needle in this artery and I don't hold enough pressure, it will bleed out into that area. That's why you have to have adequate hemostasis. If you don't do that, then you have this false aneurysm. Can it rupture? Sure, if enough bleeds into it. But a true aneurysm, this is like a genetic long-term thing. Peripheral artery disease, you see cardiologist for this and also a vascular surgeon. This is going to be issues with blood flow distally, usually affecting your legs. This is what the whole PBS exam was for. You want to check your pulses in all those areas. You can have like dependent rubor, which is like Berger's disease. And it also affects if you have high cholesterol, you just think about heart, MI. You can also get strokes. It's the same thing, except you're getting like the McDonald's like in the brain, and it narrows the flow there, and you can have a stroke from that. You can also have limb ischemia, right? You can have narrowing in your legs. So you can have a clot that goes there, that's going to cut off circulation, and then it becomes gangrenous. So it's the same principle. You can apply this to any arterial circulation in the body. It can happen. If it's peripheral arterial disease, the cardiologist is not going to be the one to clean you out. That's going to be the vascular surgeon. If it's a brain, it's not going to be the cardiologist, it's going to be the neurosurgeon. If it's the heart, then it's going to be the heart cardiologist or the cardiothoracic surgeon. So the hallmark of treatment for all these is going to be lipid reduction, antiplatelet medication, because you don't want the platelets to form because they're having microvascular leaks all the time. So you want to reduce their platelet. You put them on aspirin. You put them on Plavix. We call that what? DAPT, dual antiplatelet therapy. You can sometimes they see this, you have reduced flow, so they can stent it. They'll stent the actual vessel open. That'll improve flow and everything else there. You can get that in the brain as well. You can get mesenteric artery disease, right, from bad clots, or atherosclerosis. More commonly, it's clots in that scenario. Does that all make sense? Can happen anywhere. Arterial aneurysm, very bad. We talked about this in PD1. So number one cause is atherosclerosis. Biggest risk factor is smoking history. If you are an ever smoker, you need to smoke once theoretically. You have a risk of arterial aortic aneurysm. This is just talking about arterial aneurysms. It can be from trauma, which is like what the interventional cardiologist is doing, really. It can be congenital. If you have collagen vascular disease, which is like Marfan's and Ehlers-Danlos, you guys have heard of collagen vascular diseases? Collagen, literally what makes up the vessels. They're so stretchy. It can be from infections, vasculitis. Vasculitis is really annoying to understand. It's a very hard disease to diagnose as well. Have you guys learned about vasculitis? It's basically like all your vessels are just prone to being compromised, and they are at any time able to rupture and become inflamed. And it's very hard to treat. They usually give systemic steroids and you make them, compromised by treating them. These are like Wenger's granulomatosis, or what's it called now? Polyangiitis granulomatosis. These are like vasculitides. So it's a hard concept to understand. You got your saccular aneurysm, which we learned about in lecture 4, fusiform and ruptures. You guys got tested on this already, so that should be easy to remember. Congenital heart diseases. You guys with Emma yet? He teaches it really well. So you have ventricular septal defect is the most common. These are abnormalities of the heart or great vessels that are present at birth, usually 1% of live births. Caused to be genetics or environmentals, like rubella. To give rubella vaccine, not for you to get rubella, it's for you not to give it to pregnant women. And there's also shunts. I'm talking about shunts of pulmonary. Most easiest one to understand is like a right to left shunt, because your deoxygenated blood is mixing with your oxygenated blood. A good example of that is like a PFO, right? We talked about that. The foramen ovale, which is an atrial septal defect. So that's like a right to left. Or you can have a left to right shunt as well, which isn't as bad. And it's also like tricuspid atresia, which is like weak tricuspid valve. So a left to right shunt, not as bad. Increased pulmonary blood flow and pressure, right-sided ventricular hypertrophy and failure. Atrial septal defect. It depends on what the pressure is, really, just what it is. Ventricular septal defect and patent ductus arteriosus. PDA is going to be your pulmonary artery is going to not close after birth. And you're going to have shunting, mixing of blood from your left atrium to your pulmonary artery. You guys learned that? No? PDA? I can teach you this. You guys didn't learn any of this stuff?
We did. That's
Not pediatrics.
the PD, like.
No, this is all pediatric stuff.
Oh yeah, he's not there.
Yeah,
I think he's like on immunizations or something.
we're doing vaccines.
Yeah.
All right, I'm gonna come back to this at the end.
You should just teach us everything.
I can't. I don't know everything. So shunts is right to left shunts. That's going to be defined as cyanosis. That one makes the most sense. These are all pediatric stuff. All right, I got to draw this stuff out. I don't want to do it now. When I get to the other stuff, I'll do this at the end. Valvular something dysfunction. You can be congenital or acquired. Stenosis is it gonna open completely? Intermittency is it's backing up. Both of these, just so you know, back up into the previous chamber. I used to think that stenosis kind of made the distal chamber large. It does, but a lot of the work goes to the previous chamber. So actually, if you fix any of these issues with cardiothoracic surgery, what it does is it exposes the distal chamber. So for example, you have mitral valve regurgitation. That blood should be going to the left ventricle. What's happening is the left atrium is taking majority of the brunt of it. And then you fix it. And then their LV is shot. And it's like, well, why is their LV struggling? Turns out their LV has been shot for years, but it hasn't had shoulder load because the left atrium was taking most of the beating. Now you fixed it, and the left atrium's doing the work it was assigned to do, and now the left ventricle is being exposed and it's saying, I can't actually pump adequately. Now you have an LV left ventricular problem, which is a separate issue. So that's interesting. And so this we talked about already, semilunar valves and cusps is going to be your aortic and pulmonic. Mitral is going to be your bicuspid valve, which is 2 papillae muscles. Tricuspid is 3. First heart sound we talked about is closure of the AV valve. Second heart sound, semilunar valves. Third heart sound is S3, which is Tennessee gallop. Rapid ventricular filling, normal in pediatrics. Fourth heart sound is stiff ventricles, which is Kentucky, and that's going to be always pathologic in everyone. We learned that in PD1. And the chordae tendineae or papillary muscles, these can sometimes rupture and lead to like really bad heart failure. Regular heart flow, the valve morphology, what it should look like. So this is like a cross section looking at, I guess we're looking at it from the, well, this is the left side, this is the right side. So I guess we're looking at it from the right being on the right. So from the top, this is the top view. Left ventricle, right ventricle. Your aortic valve should look like a Mercedes-Benz sign. You can have sometimes a bicuspid aortic valve that needs to be repaired. So there's a normal aortic valve, it's closed, Mercedes-Benz, and if you have aortic stenosis, it's not closing completely or it's hard to open, and that may lead to increased afterload, so you have to maintain that and have that go through. If you have corrections to your aortic valve, it can sometimes lead to problems distally. You can have aortic root problems. This can become dilated. Heart surgery is a very crazy deal. Disorders of the pericardium. So you can have pericarditis, which is can be caused by inflammation. It can be viral, infectious, autoimmune, like rheumatoid. It could be from renal impairment as well. There's like uremia that can do it. That could be after an MI. If you have a post-MI myocarditis, what's that called? Dressler's syndrome. You've heard of that? Post-MI myocarditis. Radiation-induced or it can be malignant. Outcomes, it can resolve on its own, or it can end up with a pericardial effusion that might stay there for some time, and eventually it might cause tamponade if it's greater than 150 ml. Or it can fibrose. That can lead to constricted pericarditis. You have to remove the pericardium. So here's a thickened pericardium, and here's black is an echo. Black fluid on echo is black, and here's pericardial effusion. What's the most common vital sign change to pericardial tamponade or cardiac tamponade? No. Most common vital sign change.
The heart rate.
Yeah, your heart rate. Heart rate goes up. Sinus tachycardia. And then hypotension. Cardiomyopathy is going to be intrinsic cardiac dysfunction. There's dilated, which is the most common, which is going to be ballooning out. And there's hypertrophic, which is kind of like diastolic heart failure. And then there's restrictive, which is going to be like amyloidosis, which is a buildup of proteins in the cardiac tissue, which prevents it from adequately squeezing. If you have end-stage amyloid, you need a heart transplant. If you have end-stage dilated cardiomyopathy, you need a heart transplant. If you have really bad hypertrophic cardiomyopathy, if it gets really bad, you need a heart transplant. But of this, the one that buys you a heart transplant the quickest is amyloid. It's rare though. So dilated is congestive, progressive dilation, and contractile dysfunction, abnormal systole. It could be familial, viral, Coxsackie B, I think causes cardiomyopathy. You can have COVID myocarditis, and alcoholic cardiomyopathy is very common as well. You have dilation from that. There's also postpartum cardiomyopathy, which I talked to you guys in PD1 with the OB doctor. I told you that story. So that can also happen in young women. It's enlarged and flabby, dilation of all the chambers. Clinically is 20 to 50 years old. End stage is an EF less than 25%, and they usually bought themselves a what? Device, AICD. Here's what that looks like. It's dilated. The heart looks huge on X-ray. It's usually 2/3 the size of. You learn doing radiology now with right?
Yeah.
All right. Hypertrophic cardiomyopathy is usually abnormal diastolic filling. You'll have reduced stroke volume. This is your Schwarzenegger heart. Genetic is most common though. Like uncontrolled hypertension can cause it. It can also be from like the IHSS. It can be from like the LV outflow tract obstruction. Variable reasons of hypertrophy without dilation, ventricular septum thickening to actually, basically the weights are too light, and also like you got too muscular. Heart ejection murmur, angina, and sudden death. This is usually young athletes. You'll have a thick, stiff muscles. You have a reduced cavity here. That leads to reduced end diastolic volume. And then eventually it gets to the point where you can't adequately overcome afterload. And that's why they have the sudden death that happens. Here's an example of a dilate. Look how beefy this is. This is huge. So there's reduced volume there. Restrictive is going to be decreased ventricular wall compliance or a stiff wall. Amyloid, sarcoid, hemochromatosis can do this as well, which we're going to talk about during heme. This is a buildup of iron deposits. Radiation can do it. Radiation is toxic to everywhere in the body. So you'll hear like radiation pneumonitis. You'll hear like radiation-induced pericarditis and radiation-induced like myocarditis. Like it happens. It's just toxic everywhere. It's not always. Myocardium is firm. Ventricles are not dilated. Like it's just literally like rock muscle. Like it can't squeeze anymore. You have that S4 heart sound. You'll have heart failure, and your ventricle is kind of like small, but in some certain instances it'll be the correct size, but it just cannot squeeze, and that's from amyloid. Rheumatic heart disease is going to be delayed immune response to group A strep. We're talking about for in PD, strep throat, how this can happen. So rheumatic heart disease is going to lead to valvular abnormalities. Diffuse inflammatory disease affects the valves, myocardium, pericardium. It's a hypersensitivity reaction. There's a criteria to diagnose it. It's called Jones criteria. So it's a febrile underneath that have 2 major or 1 major and 2 minor. And these are the criteria. You should memorize this for the Jones criteria. They have it here. Yeah, Jones. J is joint pain, so migratory polyarthritis. O is just carditis, which is the shape of a heart. N is nodules. E is erythema marginatum, which is like a traveling rash. And S is like Sydenham's chorea. Your joints may move spontaneously. So that's major. That's the major criteria. And the minor criteria is like fever, just regular joint pain, elevated white blood cell count, or an elevated ESR. It's a non-specific inflammatory marker. So you either need 2 major criteria or 1 major and 2 minor. So you got to have one of these plus that to make the diagnosis. You also need a culture positive for strep. They have Ashkoff bodies under the slide. It can lead to pericarditis, and it can lead to stenosis and regurgitation, and these stenotic valves. 70% mitral. What I was saying. And it makes sense why this is the most worldwide cause of valvular disease, because the majority of the world doesn't treat every infection with antibiotics, right? That makes sense. And the mitral is the most common that's affected. So worldwide, rheumatic heart disease is the most common cause of valvular abnormalities. That's why the mitral valve is most commonly more affected. So it fits. Infective endocarditis we talked about in lecture 3. Briefly, it's microbial invasion of the heart valves or mural endocardium. Most common is the aortic and mitral valve. But the most common in drug abusers is the tricuspid valve. It can be bacteria. The heart should be sterile. The blood should be sterile. But certain bacteria travel directly to the heart. Why do you think that is? Why don't they hang on the liver?
High oxygen.
Yeah, bingo. It's like a haven. It's got literally it's the source, the most oxygen available. It's gobbling all that up. So it sticks to the heart. Which procedures can lead you to developing endocarditis very commonly? Valve replacement may be an indication for endocarditis can be an indication for valve replacement, but no. Very common thing that we got that can lead to endocarditis. Dental, right? Your gums, it's all capillaries. It's directly into your bloodstream. It doesn't have to bypass anything. Just goes straight in. You ever see people like in the movies, like the junkie, like he gets his cocaine, to brush his teeth with it, because like it goes straight into the circulation. It bypasses all that. Just like dental procedures, you have crap on your teeth. It's normal, right? You got to clean all that stuff out. Well, that stuff can very easily go into your circulation and it goes right to the heart. So strep viridans, that's an oral flora that doesn't belong in your heart. It naturally exists in our mouth. Staph exists on our skin and all our surfaces, so that makes sense as well. Usually immunocompromised people but drug abusers can happen as well. Most commonly, is tricuspid valve is the first valve that it goes to if you're shooting up something with needles, because they don't really use alcohol first and make sure it's clean and then inject the needle, get a nice clean needle, sterile. Yeah, junkies don't use aseptic technique. Indwelling catheters and artificial valves can do it. So valves can cause it, but it's not one of the most common. But if you have an infected valve and it's artificial, what has to happen? It's got to come out because your artificial valves don't have tissue, so your white cells can't actually marginate there. So it becomes like a biofilm. It's a problem. That's the same principle why you have any prosthesis and that area gets infected, like a joint replacement, and then you have it's like a nightmare because it's like the joint's literally fine, but I have to take it out because it got infected. Come on, like they're like that. The surgeon's like that's not fair, but it's what it is. They'll try their best to avoid give really high dose antibiotics. Maybe we can kill it. We'll repeat cultures. If the cultures clear up, maybe we're good. Occurs to normal valves, but at risk of pre-existing disease like rheumatic heart disease or congenital. Like if you have a valve that looks like this, like it has a high predilection to get infected. Like it's compromised, it's chewed up, it's jagged. Like it's got all the hallmarks of getting infected. We call these veggies, like broccoli. These are vegetations on the heart. You see it on echo. To diagnose endocarditis, you need, Jones is rheumatic heart disease, Dukes is for endocarditis. So this I memorize as well. Dukes is going to be definite. Okay, so you need either 2 major or 1 major, 3 minor, or 5 minor. So the boards love asking about this. So definite infective endocarditis is pathologic lesions, vegetations, or intracardiac abscesses demonstrating active endocarditis on histology, which makes vegetation. You literally see this on echo. It's open and shut case. Intracardiac abscess demonstrating active endocarditis, also seen on echo. So that makes sense. Or microorganism demonstrated by culture or histology of a vegetation of intracardiac abscess. They grew strep viridans. That's not normal. That doesn't exist in the body. It should only be in the mouth. Repeat the cultures. Still strep viridans. Get an echo. Echo's clean, but still strep viridans. It's like, they probably have that. So that's a persistently positive culture. Possible endocarditis, presence of 1 major and 1 minor clinical criteria, or presence of 3 minor clinical criteria. The minor criteria is going to be fever, a vascular phenomena. You'll have like Roth spots, splinter hemorrhages, those findings. Immunologic phenomena, blood cultures that do not meet major criteria, or serologic evidence of active infection of the microorganism, like if you have that. Strep. If you have strep viridans, it doesn't necessarily mean you have endocarditis. It's highly suspicious, especially as they're cleaning recently. Well, I don't know. Maybe they got bit by someone. That can happen too. If you bite some, it's you always get resistance on this. It's a bad diagnosis to get, and it requires basically you get endocarditis, you're on antibiotics for like 3 months.
and you have to go. You can't be in the hospital for 3 months. You can get PICC line. It's going to be in your arm. That line can get infected. It's just like a big problem. I'm not picking that up again. It's like a big problem. And then if it's vegetation is large enough, it's automatic indication for cardiac surgery. But if you need a new valve. But if you get a valve, what's the worst thing that can happen to it? It gets infected. You see the problem. The valve it needs to be replaced because it's infected. But I then have to put a new valve in something that's infected. So they will try very hard to prevent or not get stuck with the diagnosis. So major criteria is a positive blood culture, typical microrosal consistent endocarditis from 2 separate blood cultures, but when you're ordering blood cultures for endocarditis and you're working it up, you actually get 3 sets. It's the correct way to do it. Persistently positive. If you have certain bugs, if you get it, it's like automatically you got endocarditis. Evidence of endocardial involvement, echo, or new valve regurg. So here's the criteria, the major, the minor. Rejected endocarditis are always going to be like, was there any other reason why this could be happening? A firm alternative diagnosis made. Or resolution of manifestations after less than 4 days of antibiotic therapy. If I give you antibiotics for 4 days, this should not go away. This takes like weeks and months. And you should be persistently positive, 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 positive. So if it got better with a couple of days of antibiotics, it's probably not endocarditis, right? No pathologic evidence of effective endocarditis is found in surgery or autopsy after antibiotic therapy. Well, no duh. Clinical criteria for possible or definitive endocarditis is not met. So, 2 major, 1 major, 3 minor, or 5 minor. If you're febrile, you have splinter hemorrhages, you have positive cultures that are not necessarily typical of staph or strep, and you have a high risk, you're immunocompromised, and everything else, like treat for endocarditis. So when in doubt, you treat for it. So Dukes is going to be for endocarditis. Jones is going to be for rheumatic. You should know both of those. Cardiac tumors, a myxoma. Most commonly, there's also this thing like cardiac cancer, really. It's like incredibly rare. Myxoma is most common in primary adults. 90% is in the atria, usually left, or it can be sessile or peduncular, where it's like swinging back and forth, and it can actually cause damage and impair the flow. You can die if it's large enough. Rhabdomyoma is the most common in peds, as associated with tuberous sclerosis. You guys know that in peds yet? You have the tubers, little spuds on their skin. You'll learn that. Lipomas, fibroelastomas, and then there's cardioangiosarcoma, which is malignant, super rare. All right. Okay. All right, right to left shunt. The shunt is mixing of blood, oxygenated and deox. So a right to left shunt is going to be deox mixing with ox. That's bad. It's a problem because if I have a heart and I have, let's say, a PFO, it could go from deox into ox, and then that's going to go into circulation and become cyanotic. Could be a problem. But in order for this to be considered a right-sided shunt, it would have to be very low pressure. Follow? Because generally, which side of pressure is higher? Left side. So that's why these are considered left to right shunts, which is ox to deox. So all that means is you got your heart, you got shunts. Because the pressure on this side is 120, and the pressure on this side is like 20, it very easily will always overcome the area of lower pressure, whether it's an atrial septal defect or ventricular septal defect. So you'll have left to right. And that will then go into the pulmonary vasculature, get oxygenated on top of oxygenated, and then so on and so forth. So that's okay. The problem occurs if it's a right to left shunt where your pressures are low. So you have to maintain adequate perfusion to always have the left side win. So examples of these shunts is a PFO. So a PFO is going to be what I just described here, patent foraminal valley, which is incomplete closure of the foraminal valley, which when you take your first breath, it should close that as an infant. It should get closed. But in natural fetal circulation, that stays open because your lungs don't, in a fetus or in fetus. In a fetus, the lungs aren't used. They're completely never ever touched. It bypasses it with the placenta and the circulation, right? So that's why you have the PFO. So blood goes from the right atrium straight into the left atrium because it gets oxygenated through the placenta. And then you take that first breath, this closes, and then you finally start using that side of your circulation. PDA is going to be when you have your pulmonary artery. This is like a pulmonary artery, and then you got like your right and left ventricles. There's a communication here where the pulmonary artery vasculature will bypass. Again, there's two ways for it to bypass, so you really don't use your right ventricle, and it gets oxygenated through the placenta and everything else. Again, this gets closed with bradykinin, I think, and that's what allows this to close in fibrosis. But in some people, stays open. So then you have shunting of blood that should otherwise not be mixing, and depending on the pressures, it's what it's going to be. Then you have ventricular septal defect, which is you have your heart, and then you have your left ventricle and your right ventricle straight up mixing. This one's like the worst one because it's much higher pressures and it's large volumes of blood. Then you have transposition of the great vessels and tetralogy of Fallot. These are all called cyanotic heart diseases, and there's 4 of them. Transposition of the great vessels, tetralogy of Fallot, tricuspid atresia, total anomalous something. This is going back a long time. So the really one I'm going to teach you, or teach you right now, is transposition of the great vessels. You guys haven't heard of this at all?
No.
All right. So your right ventricle is supposed to terminate into what? What's your right ventricle supposed to flow into? Okay. What did I just draw? The aorta. What's your left ventricle supposed to flow into? So your great vessels are swapped. Your right ventricle is going to feed into your aorta, and your left ventricle is going to feed into your pulmonary artery. It's not. It's flipped. It's a huge problem. You cannot live with this long term. But if any adult gets this, they're dead. Why do kids survive with this for a little bit? They can live up to like 6 months, 8 months with this. What is the problem with cyanotic heart disease? You're mixing oxygen deoxygenated blood. Why are infants able to? They have fetal hemoglobin, and that's what sustains them. It has such a high oxygen affinity, they're able to overcome that. So eventually this needs to be fixed, but the problem is that pediatric cardiac surgery is awful for the child. I'm not even worried about the child that have to go through. What's a kid doing his whole life? Growing. It's not like an adult where you're fixing it's good. These often need revisions and revisions and revisions because they keep growing. These are disasters. So transposition of the great vessel, you see how that's a swap, right? So that the RV, like the flow, is still like it's going to the aorta. You're getting deoxygenated blood systemically. It's an issue that's only able to be overcome for a certain period of time.
So that's called transposition of the great vessel?
Yes. Going over time. Not my fault. Should have been done already. Atrial septal defect we explained. Ventricular septal defect we explained. Patent ductal arteriosus we explained. All of these, guess what these cause? Murmurs. These are all the murmurs that the machinery like murmur, and did you do murmurs yet with?
Okay.
All right.
So you're born, yeah.
Huh?
Yeah.
Yeah, so you guys should be experts with that. So right to left shunt defined by cyanosis. Right to left, clubbing, polycythemia, paradoxical embolism. Paradoxical embolism is like, this is when a DVT can cause a stroke. DVT should not cause strokes. It should cause a PE. If a DVT causes a stroke, that means that there's an opening and it somehow slipped through to that side. So, yeah, that's called paradoxical embolism. You have tetralogy of flow and transmission of the great arteries, same principle. And the left to right, it's going to be increased pulmonary flow and pressure. If it's a big shunt, it's late cyanosis. Like if it's like a significant amount, but that's usually later in life. And these are the types of that. To do this properly, you'd have to learn. So I'm going to show you two things, and then we're done. This is the type of pulmonary hypertension. You just look up any one of these. Pulmonary arterial, left side heart disease, lung disease, CTEPH, and unclear factors. And the other thing I'm gonna is cyanotic heart diseases. Neurology of below, transmission of great vessels, tricuspid atresia, total anomalous pulmonary venous return, and persist. I don't know this one. But that the kid ends up cyanotic. You guys learn about APGAR scores?
Yeah.
All right, so if the child's cyanotic, they do an echo on them. They're like, why it should get better. But if their score is low and they're very cyanotic or they're weak, they could have one of these things here. Transmission of great vessels, it's swapped. The pulmonary artery here is actually red because it's the oxygenated part of it. Tetralogy of below, like they're mixed. They're blended together. Very bad. Tricuspid atresia, there is no tricuspid valve. It's supposed to be there. Be ready to be used with the first breath. It ain't there. I don't know this one, and I'm not gonna get you that one. This is all Dr. Emmett. He does a great job with these things, but this is just to understand shunting. I don't mean to poo-poo it. It's not my area to. I'm going to just tell you this is what it is, but the specific details of what that is, you'll learn in pediatrics. But you should get it soon. It should be before your exam.